All right, hi everyone. So my name is Allison and I'm pleased to present the webinar today, which is on cognitive behavior therapy, strategies for supporting well-being after a spinal cord injury. So thank you all so much for joining us today. Before we get started, I'll just touch on a few reminders relating to Zoom etiquette. So we ask that you please ensure that your microphone is muted during the session if you're not speaking. And there will be an opportunity for questions at the end. So if you have any questions that arise during the session, feel free to just type them into the chat and we'll address them during the Q&A period at the end. Today we have Swati, Mehta, and Randy Upper presenting on supporting well-being after spinal cord injury. Swati Mehta, PhD, is a scientist at Parkwood Institute Research, Lawson Research Institute, and an adjunct assistant professor in the Department of Physical Medicine and Rehabilitation at Western University, and a registered psychotherapist. Dr. Mehta leads the Rehab Psych Lab. The aim of the lab is to improve activity engagement and overall well-being among those undergoing rehabilitation through online programs, including virtual group-based physical activity and internet-delivered cognitive behavioral therapy hosted on her web platform at Lawson and St. Joe's. She has received over $1 million in research funding to date and has authored over 65 peer-reviewed articles. She has been awarded the Lawson Impact Leadership Award in 2016, the Royal Society of Canada Alice Wilson Award in 2017, and the Saskatchewan Health Research Foundation Excellence Award in 2017. Our other presenter today is Randy Upper. Randy has a master's degree in social work and is a registered social worker. His experience in the field of social work has included life skills training, individual and group counseling, as well as program development and implementation. While on hiatus from social work, Randy participated as a member of the Canadian National Cycling Team and became a certified personal training specialist, PTS, for 5 years. During this time, he owned and operated a personal training business that specialized in outdoor boot camps for teens. Randy is currently working as a clinical research associate with the Rehab Psych Lab at Lawson Health Research Institute. Here, he provides clinical support to persons with neurologic conditions through the online mental health services offered by Rehab Psych Lab. In addition to these credentials, and what he finds most valuable, is his 33+ years of lived experience with a T6 complete spinal cord injury. As a means of keeping conversation going between his spinal cord injured peers, Randy and his wife, Melanie, are running a website, t6talk.com, for the SCI community. So without further ado, I will turn it over to our first speaker, Swati.
Thanks, Allison. And thanks everyone for being here today. We're hoping to talk a little bit about cognitive behavioral therapy and how we can use that to improve well-being after spinal cord injury. In terms of learning objectives, we're hoping that we could kind of describe what mental health is like for those with SCI and why it's important to incorporate those in the rehabilitation process. We want to understand what guided internet-delivered cognitive behavioral therapy is, examine the evidence for it in the SCI population. And I'm going to keep the first 3 objectives pretty brief because we want to spend most of our time applying the knowledge of CBT and practicing some skills together as a workshop. So just in terms of mental health and rehabilitation, individuals with spinal cord injury have been shown to have greater likelihood of experiencing psychological distress compared to the general population. And this is really important because psychological distress can really impede the rehabilitation process. High levels of depression have been shown to be correlated with decreased functional improvements and independence. And they can lead to greater levels of pain and greater hospital stays. So it can really interfere with people's ability to socialize and carry out everyday activities. And so because of this, it's really important to take more of a multidisciplinary self-management approach. Sorry, next slide. And so this evidence really shows that, not only incorporating medical interventions, but, complementary medicines such as physiotherapy and psychological therapy is really important when we're managing the rehab process. Next slide. And so I'm just going to give a very quick example of why it's important to use multiple approaches. So imagine you're at work all day hunched over a computer and you start to develop chronic neck pain. And you can take medication for it, like anti-inflammatories, but that really only works when you keep taking those medications. But you might start to feel, helpless and unmotivated because your pain's not going to go away. So what are some things you can do to fix that situation? Well, one thing you can do is you can talk to your occupational therapist at work and see if they can help you fix your desk so that you can get better posture. You can talk to a physiotherapist to learn about different stretches and exercises that can help you strengthen your neck muscles. But a lot of the strategies that you're going to use, you need the motivation and self-confidence in your ability to kind of carry out those activities. And so that's where a therapist can come in. They can really help you learn different strategies to help you change your behaviors and thoughts to keep you motivated and maintain some of those healthy behaviors. In terms of evidence for psychological management, cognitive behavioral therapy has been shown to have the most strongest evidence. And when we look at the systematic reviews and meta-analysis out there, it's been shown to improve things like depression, anxiety, and chronic pain with moderate to large effects. And then when we look at clinical practice guidelines for spinal cord injury, they also recommend the use of CBT as a psychological intervention. However, when we look at what's out there in the Canadian community, a survey found that only 43% of individuals really consider that they have their emotional needs met. And even those that do have access to these services, there's a really low rate of utilization because of barriers such as physical barriers, stigma, financial resources, or even access to expertise. So what can we do to help fill that gap? I think one potential solution is to use Internet-delivered CBT or ICBT. Next slide. I think it's basically based on the same principles of cognitive behavioral therapy, but it's delivered online as lessons with guided support from a trained clinician. And so it really has the potential to overcome a lot of the barriers to accessing therapy that we kind of experience with face-to-face. So things like, stigma or wait lists or physical barriers. So some of these things can be overcome by the delivery of ICBT. Next slide. When we look at the pool of data from studies comparing ICBT to face-to-face treatment, you can really start to see, I don't know if you can see my cursor, but you can really start to see at the bottom that there's no really significant difference between the two in the primary general health population. And so it's been shown that ICBT is just as effective as face-to-face treatment. And if we look at the chronic health conditions evidence, we find that even though it's sparse, we're finding similar results, that the effect of face-to-face treatment versus ICBT is pretty similar. And so ICBT has really been shown to be a very cost-effective solution. So in terms of organization, so lots of organizations in Canada, including Health Quality Ontario, have really looked at this evidence and started to recommend the use of ICBT in the general population. So here in Ontario, we have a great program called Bounce Back Ontario. And it's a program, ICBT program for those with, mild to moderate symptoms of anxiety and depression, and it's free for everyone in Ontario. It's a great program, but it's very limited for those with spinal cord injury. And so what we wanted to do was we wanted to see what we could do to tailor an ICBT program for those with spinal cord injuries. Sorry, next slide. And so what we did was we developed an ICBT program. We adapted it from an initial existing program that was developed by Macquarie University in Australia. We had a panel consisting of people with lived experience, researchers, and clinicians involved, and we met with the panel over 3 sessions. So in the first session, we kind of just got an idea of what the needs are, what are some of the contents we would need to tailor that program for for those with spinal cord injury. Based on that feedback, we created new modules, we created new resources, and we kind of went back to the panel and said, what do you think of this preliminary materials? And then they gave us more feedback, which we incorporated and finalized into our program. So in terms of our program itself, it has 5 lessons, and it does teach a lot of the skills of CBT that my colleague Randy will be talking about a little bit later. And these include things like, thought challenging, managing physical symptoms, graded exposure, and activity pacing. We also included things like homework assignments, to help people kind of apply some of that knowledge they're learning into their everyday life. And we also developed case vignettes of people with spinal cord injury and how they applied some of that CBT skills for themselves. And lastly, we developed additional resources based on what the panel recommended. So these included things like sleep hygiene, managing acute and chronic pain, and problem solving. Next slide. And one more, sorry. So once we developed that program, what we did was we conducted a small pilot study amongst 20 participants to evaluate the feasibility of this trial. In the program, what we did was we delivered the program and we delivered a once-a-week support from a trained clinician, either through messaging or telephone, depending on what the preference of the participant was. And these sessions included the therapist checking in to kind of practice those skills in CBT and see how we could use them in everyday life and tailoring to each individual's needs. In terms of results for that pilot, we found significant improvement in symptoms of depression and anxiety. And then when we looked at treatment satisfaction, we found most people were very satisfied with the program and would have recommended it to others. And it really helped them increase their confidence in managing their symptoms. And then what we did was we conducted some semi-structured interviews with the participants. And what we asked was, what are some of the positive factors that you learned from the program? And they really felt, that idea of accessibility, flexibility, and guided support was really important to them. They also really liked case stories and the course structure and design. In terms of outcomes, people talked about how, it really helped them improve their ability to cope with their illness. And one of the surprising themes that arose was this idea of mental health prioritization. So when we asked people to rank mental health compared to their other concerns and illnesses related to spinal cord injury, they said initially they would have rated it like 4th or 5th after their physical conditions such as bladder or pain management. But once they took the program, they realized how important mental health and managing that can be in coping with other physical symptoms. And so this was really surprising because we kind of realized how important this can be in managing a lot of their physical symptoms. And so based on this study, we were able to get a larger grant to conduct a randomized controlled trial. And here what we wanted to do was look at how efficacious is iCBT compared to a spinal cord injury only control group. Basically, we wanted to see and make sure that the changes in symptoms weren't due to that weekly contact they were getting from the guide. And so we wanted to give that weekly contact to both groups, the iCBT group and the education group. And so the programs were delivered on our web platform. Both groups received once a week contact with their guide. And so the only difference between the two groups was the content of the program itself and also the conversation the guide was having during that weekly check-in. So in the iCBT group, the guide was talking about, practicing the skills and tailoring to the individual's needs, as opposed to the SCI education group. It was more answering any questions they might have about spinal cord injury and rehabilitation process. So we're just kind of wrapping up that study currently. We've recruited 120 participants across Canada. And just to give you some brief preliminary results, what we've found is that the average age was pretty similar, around 49, 50 years old. There were a few more females in the education group compared to the iCBT group. The duration of injury was around 10 years post-spinal cord injury, but it ranged anywhere from 6 months to 30, 40 years post-injury. Most participants had experienced a traumatic injury and had quadriplegia and an incomplete injury. In terms of outcomes, when we look at the difference between the two groups at post-treatment and 3-month follow-up, we found significant improvements in anxiety, depression, positive affect, resilience, self-esteem, and grief in both post-treatment and 3-month follow-up, with improvement in symptoms in the ICBT group compared to the education group. And when we look at the 3-month follow-up, those things such as ability to participate and independence started to get significant as we went and people started to practice these types of skills more and more. They were able to keep and continuing to improve at their 3-month follow-up. When we look at the clinical outcomes, specifically in the ICBT group, we found, there was a significant reduction as shown before. So we found 50% reduction in their symptoms of anxiety at post-treatment, and these were maintained at 3-month follow-up. And in terms of their symptoms of depression, there was 40% reduction at post-treatment and 50% reduction in 3-month follow-up. In terms of Cohen's d or effect sizes, there was moderate to large effect sizes in both anxiety and depression, which continued to improve at 3-month follow-up and be maintained. And so you could really see that ICBT is really a feasible and acceptable form of treatment for managing emotional well-being amongst those with SCI. And really, it's a great form of using a mental health program for those that might have mobility issues for overcoming, face-to-face treatment. It can also be delivered with very low therapist burden, 15 to 20 minutes per week per client, which is where that cost effectiveness comes in, because usually face-to-face treatments is about 60 minutes per week per client. And guides can really be trained to deliver ICBT with a very short period of time. And so now that you've had a chance to look at, what is CBT, the evidence for CBT, I'm just going to pass it along to my colleague, Randy, who's going to kind of tell you a little bit about what CBT is. And we're going to try to take some time to kind of practice some of the main skills of CBT together. Thank you.
Well, hello, everybody. Again, my name is Randy. My role in the ICBT course is that of the guide. And so my job primarily consists of helping individuals get through the course, guide them in any way I can. Sometimes there's a little bit of emotional support depending on, what they come up with their thoughts. It depends on, helping them, just guide them through the material. And yes, it's usually about 15 to 20 minutes per session, and it's wonderful. I mean, as working as a therapist, I always used CBT, and then when I saw this course and saw the materials and how it was designed, I was definitely sold. And I just got to say, I love this little guy, this picture of him. Every time I see him, what comes to mind is how cool are his parents that built that for him, those little jetpack. Anyway, little aside, I've got first time presentation jitters, so hopefully I'm not going to my way through, being the first time I've done this presentation. But anyhow, I'll just get right to it. What is the aim of CBT? CBT is meant to empower individuals to self-manage their overall well-being. It's practice-based, and which means the individuals are very actively involved in the therapeutic process. It provides various skills and strategies that the individuals can apply to themselves via homework, as we mentioned before, and in particular, in our case, at the end of each lesson, there are worksheets that they use to look at the material and how they can apply that material to themselves and work it out on paper. Also the focus is on understanding the thought process of individuals and how thoughts can influence what we do and how we feel. In particular, we want to look at negative and unhelpful thoughts that tend to really loop in this autopilot momentum in our heads. Thoughts are most often the starting point when using CBT due to the vast impact that it has on our feelings and our behaviors. And when examining these types of thoughts, we're interested in assessing their accuracy. So it's when people are having negative thoughts, it's not a matter of just simply thinking positive. It's looking for evidence as to whether or not those thoughts are accurate, as this will be seen in the following examples. Next slide, please. To explain CBT for the next few slides, I'm going to use pain as an example, since it's such a common symptom of chronic health conditions and neurologic injuries like spinal cord injuries, melotraumatic brain injury, stroke, etc. Living with chronic pain can be devastating, and it's understandable how living with it 24/7 can result in the development of negative or unhelpful thoughts about pain. What happens over time is the development of kind of automatic negative thoughts and beliefs about pain. And like I said, they run kind of like in autopilot. So the immediate go-to with anything related to pain is negative, and it runs in the individual's head like a looping recording, and is really quite often subconscious. They're not aware of it. It's just the way their brain thinks about pain. These thoughts, as seen in the example, can in turn influence the individual's behavior when trying to cope with the pain, which then further reinforces the thoughts and the beliefs. And then the thoughts and behaviors have a dramatic effect on emotions and can lead to feelings such as sadness, hopelessness, isolation. So the idea is to see how we can break that cycle. Just try to put a stick in those spokes and make it stop, and that way and make changes which will enable the person to live life the way they want to. Next slide, please. So as you can see from this example used in the diagram, the negative and unhelpful thoughts influence behaviors and feelings, and they influence or interact with each other in a cyclical way. This can result in what we refer to as a vicious cycle, because as you can see, thoughts such as "my pain will never go away" leads to stop seeking treatment, which leads to feelings of hopelessness, sadness, and then they all again cyclically and interact with one another. Next slide, please. So let's take a look at the negative thought that we just saw. Okay, so "my pain will never go away, it's never going to get better." Sometimes people try to push negative thoughts like this away by, like I said, just thinking positive about the situation as a way of coping and or of motivating themselves to move forward. Although positive thinking really does have its place, we must be careful not to use it as a band-aid or to simply cover up the negative component to it. CBT works to challenge the negative or unhelpful thoughts, to assess its accuracy, and to see whether or not it's realistic. If it's found to be false, then the next step is to come up with a thought that is, in fact, accurate and realistic. Next slide, please. So as you can see here in the diagram, if you change that thought into something that's more accurate, where, "my pain is really bad right now, but what has worked to help in the past will lead to a more helpful behavior, which in turn also then helps people in terms of how they're feeling more confident or hopeful." Next slide, please. So some of the skills that CBT offers are thought challenging, graded exposure, activity pacing, relaxation training, and mindful meditation. What we are going to do, next slide, please, is now take some time to practice one of these activities. And in particular, next slide, please, I want us to work a little bit on thought challenging. So next slide, please. So the first part in the process of thought challenging is to identify the thought. So what is happening in that automatic looping message system that you're giving yourself? So this is where myself as a guide, I can play an active role in trying to help people that are finding it difficult to identify their thoughts, the negative and unhelpful thoughts. Now, quite often they might think don't exist, but once you slow down and try to pull out some of the thoughts about what they feel, they are there, and I'm there to help them identify it. And this is where sometimes a little bit of emotional support can come into play, because our negative thoughts often come from a negative place, and it can be very jarring. It can be very it can hurt, to find that you think this way about yourselves. It's amazing how nasty we can be to ourselves, and that we would say things to ourselves that we would never say to a friend. So the next stage is to examine that thought. So it's to look for evidence for the thought. So in the course, we do provide 10 questions that are what we refer to as the thought challenging questions, and they are to, again, help trigger or help direct the individual into evaluating that thought. So questions such as, is there any evidence to support this belief? Is this accurate 100% of the time? Is this something that is going to affect me in 6 months, 1 year, 2 years down the road? What would I say to a friend who had this kind of thought? So by asking yourself, or the individual asking themselves that question, that's where we evaluate that thought. So then moving on to the next step is doing something helpful. So when they're doing something helpful, it's coming up with that more accurate thought. So if you found that how you're thinking is not correct, what is correct? What is the right way to think about this? So what I'd like people to do is try to come up with an example of, well, I've got one here that we'll start with that. So we'll start with this. So the thought that the individual is having is letting their family and friends down if I don't get everything done. So what kind of questions can somebody ask themselves as a means of challenging this? Any suggestions?
I have one.
Okay.
Like, what evidence shows that this is true? Or like, what proves this?
Absolutely. Absolutely. Anybody else have any suggestions? So going based on that example of what evidence. So say that you ask yourself that question, and what kind of evidence could the person come up with? What kind of thoughts what do you think could be the outcome of that? Quite often somebody asking themselves questions like that, they'll find evidence that, you know what, it's not true 100% of the time, right? That this is something that, although it may be accurate, sometimes it's not accurate all the time. And so coming to that reality that I'm not always letting people down if I don't get everything done, then what would be the do something helpful part?
Maybe you could break down things you get to do, and you don't have to do everything all at one time, but you could do small bits.
Yeah. Yeah. So knowing that you don't have to do everything in one big chunk, that it can still be helpful by doing small little pieces. For example, and this has come up with some of the people that I've worked with, that in terms of even helping with making dinner, right? And in terms of helping to the process of making of dinner, to serving the dinner, to then clearing the table and all those types of things. Something that they were it was their job, it was their responsibility in the family, and felt that because they can't do that anymore, that they're letting people down. But in reality, they did help with some of they would set out the cutlery and the napkins. They would helped to load the dishwasher after the meal was done. So they actually did help with little pieces. And once they were, they identified that for themselves, then they moved to do something of, I might not be able to do everything like I used to, but I am still contributing. I am still doing something to be a part of the family and to help with the process. And pardon me, tickle in my throat. So that's an example of how I would help guide somebody through that process if they were having difficulties, is try to find ways to trigger their memories or their thoughts, to try to, again, ask those questions to look for evidence.
Randy, do you want to try another example, perhaps, so that people can get a chance to practice a little bit more?
What do you have in mind, Swati?
Well, we can let the audience come up with one. If there aren't any, we can think of one ourselves. We'll give the audience a minute to come up with something, just in case.
Yep.
Randy, this would be pretty general, but I sort of hear from people, and one of the negative thoughts is that things will only get worse; they will never get better.
Yeah.
Is something that I often hear. So I don't know if that's one that you can kind of use as a bit of an example.
Absolutely, and very similar to the example I gave earlier with pain. There is that sense, particularly at the beginning, I find, when people think that that's right, that sense of hopelessness, that there's, this is all they know, there's no way of changing it. That does come up quite frequently. So what are some of the questions, again, that someone would ask themselves to combat that type of thought? How would someone look for evidence for that?
You might be able to think back to a hard time that they had in the past and whether they were able to accurately predict how that would pan out for them.
Excellent. Yeah, look for evidence. So that's another big thing, is not only looking for evidence that that would support that thought, but what evidence do you have that shows that this is not accurate 100% of the time? Because being in the throes of the grief following an injury, it is sometimes very hard for people to look back at their achievements and the successes that they've had to date. So that's really good.
Maybe looking at your health status and at your last physician's appointment, and they said that things are stable and things are not getting worse. So there might be evidence from healthcare providers.
Yep. So to be able to support that there has been some movement forward, although it's a little bit flat right now, it's better than it was. So if we move on to the do something helpful based on those, what would you put there? I think with the healthcare provider example, that's great, because the person would be able to tell themselves, you know what? No, things are improving, that there has been evidence. My doctor even told me.
I think there's some value in in this kind of an instance as well, with sort of peers. Can you talk to some people who've gone through something similar, and have seen improvement over time, albeit it could be a long period of time, but improvement in function and that sort of thing?
Absolutely. I think peer support is so important. So I think it's a very valued resource to have, and thankfully a lot more of it is available now. So I know from my own personal experience going through the rehab setting, I was always so thankful when other people would, or people with injuries who had come back to the rehab hospital after a surgery or something, that had been out living in the real world for, you know, a number of years, that you could get so much from them because they've actually been living, you know, with the injury. And it was, oh, so valuable. So there are times when, now when we take a look at looking for the evidence, there are some times when those pieces, you're going to find that there is a little bit of truth to it. Well, with that, we also in the course have an extra resource for structured problem solving. So when people do actually find that negative or unhelpful thought that they're having, there is some truth to that, then it's a matter of using the structured problem solving as a way to cope with that reality. So there are other skills and other things available that we teach in the course that will help people in both scenarios, both situations. So to get to, you know, thinking accurately and how that's going to impact their overall well-being. So we'll move on next to the next activity, which is graded exposure. So a lot of people may have heard of graded exposure when it comes to things like overcoming different fears and phobias, is often used, or has been used in those cases as well. But how we use graded exposure is we use it as an effective strategy for overcoming fears, worries, doubts, and managing all sorts of physical and other day activities, tasks, and situations. Many people after an injury will really start to avoid tasks or activities because of, you know, any number of unhelpful thoughts or feelings, you know, such as fear of falling and re-injuring themselves, feelings of hopelessness, and, you know, just an overall feeling of being less than. Graded exposure allows people to overcome some of those worries and helps to help them achieve a larger goal. The idea is to first set an overall goal, and it's important to make to say that the goals must be not only achievable, but they have to be realistic. And what they do is the individual identify an overall main goal, and then think of smaller steps and rate them from easiest to hardest, and then use those in a safe way to gradually get to the point of reaching their goal. In this example, I'm going to get you to help a client achieve her goal of getting back to gardening again. And this is actually a real life experience that I had with a client. She had a spinal cord injury, and prior to the injury was a very avid gardener and had very extensive gardens around her home, which she was very proud of. After a traumatic injury that can result in such physical changes in physical functioning, individuals may avoid participating in activities they once enjoyed for a number of reasons. Fatigue issues, pain, fear of further injury, and it being different than before. A lot of people have a hard time getting back to doing things they enjoy just because they feel it's not going to give them that same sense of accomplishment. But she really wanted to get back to gardening, and had that fear of causing further injury, and could not even think of how to begin to get back into the gardening. In the ICBT course, she was in what we refer to as the avoidance of activity cycle. So what I'd like you to do is take a look at these 5 smaller steps to achieve getting out and gardening, and list them from easiest to hardest. So your list might look something like this. And the idea is to start with something like say, sitting down and mapping out the gardens around the house. She could just sit down at her dining room table and say, look, these are all the gardens around the house. Then move on to the point of determining which areas of the garden are most important versus those which she could just grass over, and just really get to that point where she could actually be out gardening for about 10 minutes at a time as a start. So as a practice for this activity, think of something that you would like to do. You know, make sure that it's safe, realistic, and in cases of people with injuries, it's always important to make sure that they check with their doctors prior to participating in things. So can anybody give me any suggestions on what would be something an individual would like to do? I had a suggestion, or I had an idea of start exercising again. So if this is the main goal, what are some of the smaller little steps that the individual can take moving towards that goal?
It'd be important to kind of identify what type of exercise, you know, whether it be something you're going to do at home, or are you actually going to go somewhere and do it? You know, is it going to be, you know, what kind of muscle groups you're going to be using and that sort of thing?
Right. So if they're going to go out to a gym or a fitness center, as opposed to doing some kind of internet-based physical activity, is what you're saying. Anybody else have any suggestions?
You could think about what you need to start exercising again. So if you need to get a gym membership, or if you need workout clothes, things like that.
Yep.
I think you could check with your local Y. They have good programs.
Okay. So see what is available before you choose.
Correct.
Yep.
Maybe finding a peer support to help with the early stages of the process.
Awesome. Yep. Find somebody who can give you some guidance in terms of, you know, what they do, what their routine is. Awesome.
I think you'd have to know what your goals are. So because exercise before a spinal cord injury and after are very different. So what would be your goal? Is it to build up strength, and kind of why? You know, like I want to build up strength so I can wheel better, or what that is, you know, and break it down, because some people with high levels of disability can still exercise, but they kind of need to attach that to a goal. Well, what good would it do? You know,
Right.
If I can't run anymore, then, you know, what's the point?
Right. So again, something that's realistic in terms of a goal. Yeah.
And that may be measurable, or and that would be the input from other people. It could be something that was designed by a physiotherapist or recommended. Sometimes they do that in rehab, or sometimes you might need another consultation. And the suggestion of the Y is great. They will help do an assessment and measure the goals there if you have a YMCA program.
Yeah, that would be great. So all of those are awesome suggestions. Yes. So all of those are little chunks of similar types of activities that could be steps towards the main goal of exercising again. So then once you've identified what those little activities are, and you've ranked them, then the next step is to start at that easiest task or activity, and then move your way up to that final goal. And it's something that we make sure that we do in time. It's not something that we want to rush with clients. Next slide, please. So the advantages of ICBT, and I see I'm going long, so I'm going to try to get through this quickly. So advantages of ICBT, as said, very personalized. People will come in with any number of reasons for wanting to be in the program, and the reasons for depression and their thoughts, and it's all very it's up to the individual, and especially with setting the goals. Individuals are involved in the treatment process, developing goals, so they're more likely to stick to it. Must learn to be self-aware, which is great because quite often, you know, we just run in that autopilot, and it's nice to know, you know, why you behave certain ways and how you think, and be aware of your emotions and your feelings. You can use it with other treatments. So in terms of a therapeutic tool, ICBT or CBT can be used in conjunction with other modes of therapy. And you can also learn how to cope. If you learn how to cope in one situation using these skills and strategies, you can transfer those skills to other situations. I often refer to it with the participants as, you know, adding tools to your toolbox that you can then pull out when you need them. Next slide, please. So the disadvantages of ICBT, there is a lot of homework. There is a lot of work to be done. Therefore, the individual must be motivated to complete the course, and that it's more challenging for those who are not. And it takes time to build these skills because they are practice-based. Again, you need that motivation to keep yourself moving forward. The big one is you have to confront your emotions and anxieties. So it can be disruptive. And so we, as a guide, I can provide a certain amount of psychological and emotional support. However, I'm not working as a therapist. So if there's need for that, then we will make sure that we refer to other services that are available. Next slide, please. So clinical implications. ICBT is a feasible and acceptable form of treatment for managing emotional well-being among persons with SCI. And it can be delivered to clients with concerns with mobility and other secondary conditions and boundaries. There are multiple boundaries when it comes to accessing services for those with mobility issues, from transportation to cost and all those other things. ICBT can be delivered with lower therapist burden. As was said earlier, you're looking at 15 to 20 minutes on average per week per client. And also the guides can be trained to deliver within a short period of time, as Swati mentioned earlier. Currently, we are also working on other programs, and that is to tailor the ICBT program for other populations, such as those with brain injury and stroke, and also to what we refer to as care partners of those with SCI. So I think Swati might have had a few other closing words to sum things up.
Yeah, sorry. So Allison, can I get you to go back 2 slides? One more. Yeah, that one. So based on our just findings from the randomized control trial and the pilot study, we're actually fortunate enough to have Spinal Cord Injury Ontario support the program, and they've been partnering with us to offer this service to all of their clients. So if anyone is interested in the program, you could apply through the QR code that you see on your screen. And you can also contact us if you have any questions or concerns, or Spinal Cord Injury Ontario directly, so probably through their peer networks. So the program is through our lab at Parkwood, but it's promoted through SCIO and funded through their programs. And in terms, as Randy mentioned, there are the other 2 programs that we're kind of three programs that we're working towards, the brain injury and stroke. And then we're just launching the Care Partners for those with SCI program to help them with their mental health well-being. Again, you're welcome to email us if you have any questions or concerns, or check out our lab website to see all the programs that we do offer. And then lastly, we just want to acknowledge all of our patients and our funding and collaborators that help us with our programs to kind of support us. And then we're happy to answer any questions that you guys may have.
I see somebody asked if this is only available to people in Ontario.
Yep. So currently, if we go through Spinal Cord Injury Ontario as a client, of course, it would be only for those with through Ontario. However, we do have a little bit of research funding. So if you were outside of Ontario, it would be a research study that you would be participating in. And all that would involve is answering a few extra questionnaires just to see how you're doing. And so that would be the difference between participating through Spinal Cord Injury Ontario versus through as a research study.
Oh, Jamie, you have a hand up?
Yeah, I'm. Thanks so much, guys. I may have missed this, and it may have been discussed, so pardon me if it was. But how the treatment itself, was it done via phone, video? And then how did you overcome some of the technological barriers that would be with some people who are maybe not adept or have equipment?
Yeah, so previously, when we did the research study, it was mainly through either email or telephone chat with Randy or myself. We found that most people, I think, preferred the telephone, and maybe Randy can speak to that as well. But with the new program, we've actually integrated a video conferencing software into our web platform. And so people that might feel comfortable with video chatting, that's also available. So it's basically just based on people's preferences. In terms of concerns with, internet or low band like data issues, we are able to also print the information and send it to people and then kind of help them work through it through telephone, just for people that might not have that same access to internet services.
Yeah, absolutely. People tend to want the telephone, like want that interaction with me as the guide. I mean, sure, there are still some that want to do it just through messaging, but the vast majority, it's through telephone. And the printed material has come in very handy for a number of participants that only, for example, have cell phones and didn't have laptops or tablets and that kind of thing.
Melanie, I see you have a question.
Yeah, do you have a set start time for this? Like, does it run in sessions, and how would somebody sign up?
Yeah, it's a rolling admission. So if you click on that link that I put up, Allison, maybe you could bring that back with the QR code. Or
I don't know how to use that QR code.
Can I get you to email me and I will send you the information?
Sorry, I don't know.
Sorry, I thought
QR code.
I thought that would be easier, but
no, not for me. I'm already into a technical. Like, what am I supposed to do? Put my phone
Yeah,
up?
Melanie is pretty old.
I'm gonna just find the actual link and put it in the chat.
That would be great.
Yeah, and so basically it's a rolling admission. Once you complete the questionnaire online, you can set up an appointment with us to chat about, the program itself and get some more details. And you can start the week after, so there's no wait period. We usually just start you whenever you're ready. Yeah, and I
know some people I think this would be great for, and I just wasn't aware that it was up and running yet. So yeah, awesome.
So the link I sent is the link for the SCIO service delivery program. If anyone's interested, because maybe they're outside of Ontario, I'm happy to give you the research link as well.
Yeah, I just clicked on that. So this one has got all the people across the top, and you start by saying you've been diagnosed with a spinal cord injury. So that's the way they begin.
Yeah, so it's about a
Okay.
15-minute questionnaire that kind of gives us a
Okay.
background of your mental health and needs.
Okay. So that's the doorway.
Yeah.
Okay, cool.
Yeah, at the end, you get like a booking form where you can basically book a time to chat with us.
Oh, okay.
Yeah.
And is there a site where you have some more information? So if I told a client about this, it's a bit daunting to go and not see the information before you have to start answering questions.
Yeah, so I will send you our website, like our actual
Okay.
platform website, which gives you a little bit of background as well.
Okay, that would help.
Yeah.
Because otherwise they're depending on me going, I don't know, it sounds good.
Yeah. And I'm just going to send the link for the research study as well, because that's been requested.
Yeah, cool. QR codes.
Sorry.
I know, I looked at that too and went, ah. I
Oh,
thought
I'm glad, Randy. Oh, I
Yeah.
don't feel so bad now, you know, because I need some therapy for this.
I looked at it, it was like one of those pictures that you used to have to stare at to see if there was any image that came out of it.
Oh,
So
yeah, yeah. I
that's what
see
it reminds me of.
elephants. Yeah,
Yeah.
cool.
All right. Maybe in the essence of time, if there aren't any other questions, we're approaching 1 o'clock. I really want to thank Swati and Randy for just such an excellent presentation and, you know, giving us an update and information about this project. I think it's so valuable. So again, thanks for taking your time to do that. Thanks for everybody taking their time to attend today and the interaction. I'm not sure, I was a little bit late in coming, so I'm not sure who did the introductions today. I think it was probably Allison. We do have another webinar coming up. Allison, do you know when that is? Do we have a date on that?
It will be early May.
Okay, and that's the one on nutrition, which has been a topic that's been coveted by this group. So that one will be a really great presentation as well. And everybody keep your eyes open. We'll send out some invites for that. So with that, I'd just like to say thanks again to our presenters and everybody for attending, and everybody have a great rest of the day.
Thanks, guys.